I'm Thomas Baldrick at ASH 2015. Happy to have with us Dr. Alok Khorana from the Cleveland Clinic. We appreciate you, sir, for coming by.
Thank you.
Let's talk about a study of yours, current practice patterns and patient persistence on anticoagulant treatments for cancer-associated thrombosis. What are the major factors with this particular work?
So, low molecular weight heparins, which are daily self-injections, have been recommended for about 10 years as the best treatment for cancer-associated thrombosis. And that's recommended by the ASCO guidelines and the NCCN guidelines and so on. But nobody really knows what's happening in the community. And challenges with using that specific class of agents is it's an injectable, so it's a daily self-injection. And especially in the US, the cost of daily self-injections can be prohibitive, and direct-to-patient costs can also be challenging. In recent years, other anticoagulants have come on board, and so we decided to do a study to see what was happening in real-world setting, what were patients getting prescribed. What we found was that about half of patients were still getting warfarin, which, certainly low molecular weight heparins are better than warfarin, and many people would argue that the novel oral agents are also at least as good and maybe slightly better than warfarin. But despite those recent studies, warfarin remains the dominant anticoagulant used in the current setting. About a quarter of patients were getting rivaroxaban, which is a newer oral anticoagulant, and a quarter of patients were getting low molecular weight heparin, which is the guideline-approved treatment in this setting.
What were the key results?
We found that cancer patients, first of all, even though VT is generally manageable in the outpatient setting, only about 10% of patients were getting managed, diagnosed, and treated in the outpatient setting. The majority of patients were getting either emergency room visits or getting full hospitalization, sometimes as long as 6 to 8 days. And that, to me, is really surprising. There's a lot of drugs available that we could just treat patients in the outpatient setting. Most patients with blood clots, DVT, even many PE patients are really safely managed in the outpatient setting. At the Cleveland Clinic, we do this all the time. We have a centralized service that just takes care of cancer patients with blood clots. So I'm surprised that many patients are being hospitalized when they don't really need to be.
How do you explain that 10% number?
It's very surprising to me, and I don't know that I have a good explanation. I think part of it is just logistics. Many community-based practices are sort of far-flung. If a patient calls with symptoms of blood clot, they might just say, hey, go to the emergency room or go into the hospital because that's the easiest way to manage this. Whereas in larger cancer centers, you could bring them into a walk-in clinic or some type of specialized service. So that may be part of the explanation.
So what does the data in this study show you?
It shows that, in general, first of all, we should do a better job of managing these patients in the outpatient setting. Second, we should be more compliant with the guidelines which recommend low molecular weight heparin monotherapy. And really, it's time to move away from using Coumadin. There's a lot of drug-drug interactions. There's a lot of, there's some bleeding risk associated with Coumadin. So it's important we sort of, take into account the newer treatment paradigms for this illness.
Where's your future look for this?
Lots of ongoing trials comparing low molecular weight heparins head-to-head with rivaroxaban or with other novel oral agents. So those studies should be coming out soon. Those data presented at ASH today about use of rivaroxaban at a couple major centers. Sloan Kettering was one of them, and it looks like it's okay to use in select patients. So I think sort of developing more nuance and which patients should be treated with which agent is sort of the next step.
Dr. Khorana, let me just ask you your opinion of the data presented here at ASH. What are your thoughts on it?
I think we are finally making trends toward a more patient-friendly approach, which is we don't want to treat all patients the same way. We want to find the high-risk patients. We want to treat them with more intensive anticoagulation strategies. We also want to find the low-risk patients, and we want to treat them with less intensive and more patient-friendly strategies.
Thanks again. Appreciate your time.
Thank you.